webinar today is part of the Injury and Violence Prevention Center's Research to Practice a webinar series. And we, along with our friends in the Firearm Injury Prevention Initiative, host monthly webinars on injury and violence prevention topics. So thank you for joining us for this today. If you want to hear about future webinars, we do have a newsletter. You can contact us and get on our mailing list. The next webinar will be November 14th from 1 to 2 p.m. And the title of that is A Public Health Approach to Firearm Injury Prevention, a focus on community firearm violence. And there'll be 3 speakers for that: Dr. Quentin Myers, Dr. Ben Lee, and Ginny McCarthy. So we'll be excited to hear from them about their work. And then just a heads up for the December webinar that we're putting together, it will feature Dr. Laura Schwab-Reese from Purdue. So that will be a fully virtual webinar. She's at Purdue, and we don't have the title for that yet, but we know it'll be about the National Child Abuse Hotline. So more details about that forthcoming, and that'll wrap up our webinars for this calendar year. And then one other announcement before I introduce our speaker today. Just wanted to let folks know, if any students are joining this webinar today, we do have student funding available twice a year. The call for submissions is open right now. Those are due November 30th. So if you are a student or trainee, we do have student funding available right now for independent projects. And with that, I'd like to introduce Katherine LeMasters and her talk today, The Epidemiology of Health Equity for Those Impacted by Mass Incarceration. Kate is an assistant professor here in general internal medicine, and she studies social epidemiology and health equity with a focus on mass incarceration as a structural determinant of health inequity. And she's a recent transplant to our campus, joining in June. Is that right? Is that when you got here? July, sometime this summer. So a very recent transplant to our campus. Very happy to have her join our faculty here. And she comes to us from the University of North Carolina, Chapel Hill, Gillings School of Global Public Health. And with that, I'll turn it over to you. And Kate, as you start talking, if someone on Zoom, like I'll call Sophie, if you could just be our sound check, let us know if the volume's loud enough, give us some feedback in the chat so that we can make sure that everyone online can hear us well.
Great. Just, let me know if I need to project more. But yes, thanks so much for having me today. As Ashley said, my name is Kate. I'm a very new assistant professor in GIM, but I'm a public health person, so I'm glad to be over here with you all, and just finished my PhD in Epi in May, so very, very new. And we'll be talking broadly about mass incarceration and health today. I'm hoping this can be conversational, so feel free to ask questions throughout if any pop up, and hoping that it's only about half the time of me talking as well. So first, I think when talking about this work, it's important that I talk about the stance and position of myself in regards to the social and political context of this work. So in 2019, I visited the prison where a dear friend of mine was incarcerated. And through our visits and conversations, I realized that a pervasive cause of health inequities in the US, mass incarceration, was really missing from our understanding of social and structural determinants of health. And I had done my MPH, was starting my PhD, and realized it was never discussed in any of my coursework. And this really led me to pivot my work and begin researching mass incarceration, which I've been doing since then. I also myself have not had personal involvement with the criminal legal system, and recognize my privilege in that as a white woman working around a system that primarily affects Black and Indigenous communities. I have conducted research inside of probation and parole offices, as well as at treatment centers, but have not conducted research inside prisons or jails, largely due to the COVID-19 pandemic and at the time, and now staffing issues are often cited as reasons to kind of not let researchers in. I'm trained as a social epidemiologist, and I take an interdisciplinary perspective and an abolitionist approach to studying the system of mass incarceration as a public health crisis, and I'll explain more of that approach later. So today I'll walk through some shared language and just kind of explain more of the criminal legal system, which is a big black box, I think. I'll give some background and history on mass incarceration in the US, an overview of kind of how mass incarceration relates to health. Then I'll walk through some relevant research. I'm not going to spend a ton of time on one specific thing, but just touch on a few different kind of health outcomes I've looked at or systems I've looked at, and happy to expand on any of those and talk about some potential future directions as I'm just kind of getting started and plugged in here to the community. So first, there'll be a lot of terms I kind of throw out here. Feel free to ask for clarification. So to start, I use the definition of mass incarceration to be a system of social and racial control that arrests, convicts, imprisons, and supervises individuals. It affects those that have direct involvement in the criminal legal system, as well as entire communities where that's concentrated. And I focus really on the US system here, where the scope and scale of mass incarceration are historically and internationally distinct. And within criminal legal involvement, we have arrests, which are generally folks' entry point into the system made by city or county entities most often, then a charge or conviction determined by a court. And then there's kind of two main realms of sentences or punishments people receive. So first we have community supervision, which is generally broken into two main categories. So probation is often a sentence in lieu of incarceration that allows someone to remain in the community under supervision of a probation office. A lot of my work is focused here on probation. Parole is then a type of conditional release from prison. So it's part of someone's prison sentence, but they're also supervised in the community. Both forms of this are thought of as a less severe punishment than incarceration, but they're often incredibly restrictive and disruptive in people's lives. And people have mixed views who've experienced this as to kind of how harsh it was, and sometimes preferring a longer sentence so that they didn't have to try and meet requirements in the community. Then incarceration is also broken into two primary categories. So jails, which are usually run by a city, a local district, or a county, housing people who are newly arrested, awaiting trial or sentencing, or those sentenced to less than a year. I've been learning that in Colorado, it's even a little more nuanced here, with the county and city jail and probation system being separate from the rest of the state. And the cases they take at the city and county depend on the level. There's like another complexity of city, county versus rest of the state that I didn't have in North Carolina. So that's unique. Then prisons, which are longer term facilities that tend to be under state or federal jurisdiction. Every state has at least one federal prison in it, but those are under a federal system and kind of rules versus state ones. And this is all for adult involvement. So juvenile systems are under their own jurisdiction. And so the system and the pattern there may look different. To orient you here, this is the rise of mass incarceration from 1980 to 2020 with years on the x-axis, and on the y-axis, the number of people involved in the system, and these trends look similar when we account for population growth. So starting in the 80s, we saw the system grow dramatically from a complex combination of the deinstitutionalization of folks with mental illnesses, the so-called war on drugs, and punitive sentencing laws, including mandatory minimums, so mandated sentence lengths for first-time sentences, and 3-strike laws or mandated life imprisonment for some third-time sentences. And while the number of people under control of the system has decreased in recent years, it's still incredibly high, and by far the highest rate among high-income countries. There's also preliminary data showing that involvement has begun increasing again after 2020. So you see this like sharp dip at the end, but that's really rebounded because a lot of those dips were just for delays in court. They weren't actually for like fundamental changes that were made to the system. We also see that since 1980, when consistent data were collected, probation has been the most commonly used form of sentencing, not prisons and jails, which we often, I think of the most. And then briefly, just a bit more history on how we got here, which again, everyone here may know, but just it's kind of how I try and think about this work in a much longer time span. So a lot of scholars, including legal scholar Dorothy Roberts, have laid out kind of the racialized notions of criminality and social control in the US dating back to slavery. And while this was abolished in the 13th Amendment, it explicitly allowed for slavery as punishment for crime. So kind of really starting our system as we know it. Then creating Black codes that criminalize Black individuals for not having proof of employment, and the system of convict leasing, which replaced slave labor with this quote kind of free Black prisoners. And while this then legally ended in the 30s, we've then had legalized segregation and other racially discriminatory laws until the civil rights era. And immediately after is when we saw this huge increase in mass incarceration, as shown here by criminal legal involvement. So it's unsurprising that involvement in the system is also not random. We see these massive racial inequities at all levels of involvement, based in currently racially implicit discriminatory policies that replace those more racially explicit discriminatory policies. And then I'd like to provide a broader public health perspective to my work within the system. So my work is based in the understanding that the system of mass incarceration is really deeply flawed, that mass incarceration is a public health crisis, that policies have used this system to address what are public health concerns like mental illness and substance use, and have largely targeted marginalized groups, particularly Black communities, in doing so, leading to unprecedented levels of inequities in incarceration and in community supervision. And that those in the criminal legal system have worse health than the general population due to pre, during, and post-incarceration conditions, all of which I'll touch on some, but I'm happy to expand more on those. And this poor health really extends to their families and communities as well. So now I'll read a policy statement by the American Public Health Association on carceral systems that was released in the wake of the COVID-19 pandemic, as prisons and jails were home to the largest single site outbreaks of the virus. So the American Public Health Association recommends moving towards the abolition of carceral systems and building in their stead just and equitable structures that advance the public's health by urgently reducing the incarcerated population, divesting from carceral systems, and investing in societal determinants of health, such as housing and employment, committing to non-carceral measures for accountability, safety, and well-being, restoring voting rights to formerly and currently incarcerated people, and funding research to evaluate the policy determinants of exposure to the carceral system and proposed alternatives. So for some scope now, there's about 2 million folks in prisons and jails in the US at a given time. And this is a chart of number and proportion of folks in different types of custody. If anyone's interested, I often use the Prison Policy Initiative. They break all these types of involvement down really well. And so most people here in state prison systems followed by jail, but most of those individuals are not convicted, so probably can't read this, but this is all not convicted individuals, so the vast majority. And then you have federal prisons and jails, followed by ICE detention, youth detention, and you can see that here, also involuntary commitment, which I know is kind of an increasing crisis in Colorado, which I'm learning more about, but don't have a lot of expertise in. And another thing I'm going to note is these kind of they're called Indian country jails, so jails under the jurisdiction of federally recognized tribes, whose system is, it's jails specifically, and they're those tribes own that data, and so it's not always connected to the rest of criminal legal data. So it's just something to note, is it's often excluded when you look at data on the system at a national level. And another note is that this is a snapshot. So almost 11 million people cycle through jails every year, and the average length of stay is 72 hours. So this is a huge undercount of people touched by the system in a year. It's a snapshot at one point in time. This is taken like one day a year who's currently incarcerated. And while most people think of mass incarceration as just those in prisons and jails, it's actually the minority, as I said, with that kind of chart. Most individuals are on community supervision, with over half of individuals being on probation. So there's about 5.7 million individuals under control of the system at a given time. There's also kind of unsurprising huge racial and gender inequities in the system. So 1 in 3 Black men are likely to be imprisoned in their lifetime, and that's 1 in 17 for white men. And we also see similar disparities for women. So to add to a lot of terminology, mass incarceration kind of implies that the system affects the masses. So some research now uses the term hyper-incarceration because it's hyper-concentrated in communities of color. Yeah. The system's also a revolving door. So current involvement often leads to future involvement. So among folks released from a prison, about 2/3 will be rearrested in 3 years. This is due to individuals upon release often struggling to meet probation and parole requirements, experiencing housing insecurity, unemployment, a lack of social support, and a lack of access to community-based services. In fact, of those arrested while on probation and parole, almost half will be arrested for a violation of probation and parole, not a new charge. So that's like failing to pay your fines, not doing, or failing a urinary analysis, not doing all of your mandated treatment, maybe because it's during your workday. It's not related to new charge. So as emphasized by APHA's recent statement, I want to note that in the last decade, or now maybe 15, 20 years, there's been a lot more public attention, I think, paid to the epidemic of mass incarceration and its effects on health. So there's a few things that I think are pretty well documented and that we know well. So we know that the system of mass incarceration disproportionately stops, arrests, convicts, imprisons, and supervises Black individuals, disproportionately affecting the health of these communities and making involvement in the system really normalized for a large part of our country's population. And while this is well known in research and by the families and communities experiencing this, I think it's gotten a lot more widespread media attention recently, really starting with the murder of George Floyd at the hands of police in 2020. And that was also in the COVID-19 pandemic, when I think we saw this wave of reporting really recognizing for the first time on a mass scale or on a national level just how harmful incarceration was for health, because we saw this really clear example of infectious disease spread while folks were inside prisons, people cycling between jails and communities. We saw that really lead to spikes in cases, and the mental health effects of confinement when people were put in solitary confinement, which is internationally recognized as torture for COVID containment. And I'll talk more about conditions of confinement and solitary later, but I think that was like a kind of a first more national level reckoning with this. There's also been broader recognition of how the epidemic of mass incarceration overlaps with other crises like the climate crisis. So climate change is already making conditions worse for those incarcerated. For example, most prisons don't have AC at all. And there's also this deeper understanding of the long-term effects of prison on health post-release. So those recently released have over 40 times the likelihood of overdosing soon after release compared to the general population. And I'll talk more about some of that work. So putting this in the context of the socio-ecological model, or UNC's probably favorite way to think about health, individuals experiencing criminal legal involvement, we know, have worse health during and after incarceration for both physical and mental health. We also know that having a family member incarcerated harms the health of non-incarcerated partners and their children in multiple ways. High incarceration prevalence in a community also compromises community health. We know there's increased community level HIV incidence and worse community mental health. At a societal level, it contributes to racial health inequities, given its direct and indirect consequences for health and disproportionate impact on Black communities. And lastly, because the US incarcerates many more individuals than other developed democracies, mass incarceration may be contributing to our lagging performance of health indicators such as life expectancy, is of just how many people our country has incarcerated. And so all that's to say, I think it has implications for health equity that extend beyond the criminal legal system. So for folks in public health, not necessarily studying the system itself, it has these really broad implications, I think, on our society and societal health that are just important to keep in mind in studies and questions we're asking in analyses. So now I'll give a few examples of health conditions overrepresented among those involved in the criminal legal system and how that maps onto my work with kind of a brief overview of each. And again, I'm happy to talk about any of these. So I'll talk about some work on HIV and PrEP, overdose, COVID-19, kind of criminal legal data, particularly around suicide, solitary confinement, and probation. So first, HIV prevalence among those with criminal legal involvement is 5 times that of the general population, and an estimated 1 in 7 individuals with HIV pass through the system every year. So while incarcerated, folks are at increased risk of coming into contact with HIV through unsterile needles, tattooing, and condomless sex. And following incarceration, individuals often rapidly re-engage in behavior that may increase this risk, such as through needle sharing and injection abuse. And that makes periods following incarceration really high risk for community-based HIV transmission. So I worked on the SPECS cohort, which is the Southern Pre-Exposure Prophylaxis PrEP study, which was the only cohort looking at HIV prevention among those on community supervision. And it's a longitudinal cohort following folks up for 18 months. And everyone was clinically indicated for PrEP here. So at high risk for HIV, but HIV negative. And it was in Kentucky, North Carolina, and Florida. The main finding here from the cohort leads is that almost no one was on PrEP at baseline or throughout the study. So they're now looking more about why, how to increase use, et cetera. And they've used this kind of schematic of the socio-ecological model to think about PrEP acceptability, HIV risk perception, stigma around HIV, and things like stable housing that influence someone's ability to prioritize healthcare. What I've worked on more so is kind of leveraging this really unique cohort to study other health outcomes and other issues. So we looked at the collateral consequences of COVID-19 for those on probation and parole, and competing needs and priorities to accessing care, any type of healthcare while on probation and parole, and like retention strategies for those involved in the criminal legal system, because this is a population with a lot of other needs and priorities. So answering our calls and surveys is not a high priority, but we know it's important that these folks are captured. Something else I'm happy to talk about is in our other kind of longitudinal cohorts that aren't focused on criminal legal involvement, they often just exclude people when they're incarcerated. And also a lot of our work just misses kind of how our programs and interventions affect this population, and they're really important, and they often have a lot of health needs and suffer from a lot of barriers to maintaining health. So I think it's just kind of important to think about in this work, kind of how these folks are captured or excluded from our studies. Another really important health outcome here is overdose, and maybe something folks in this group work on, maybe more so, which is the leading cause of death post-release due to a number of factors. So individuals often lack access to medication for opioid use disorder during incarceration and post-release. They often lose tolerance during incarceration and then overdose when using drugs at pre-incarceration levels, and experience housing instability, unemployment, and low access to social services, which all increase risk of overdose as well. So we worked on some evaluations of jail-based MAT services back in North Carolina, and these sorts of services are strongly recommended so that individuals can continue treatment while incarcerated and hopefully initiate as well. But I think it's always important to be clear that individuals shouldn't need to be incarcerated to get this type of care, but a lot of counties don't have these services. So trying to ensure these programs are in place in communities when they're being built up in jails so that there can be continuity of care is really important. And this sort of treatment was also mandated by a House bill last year, which I'll talk a little bit about in a different way here. Where here at CU, I'm working on analyzing Colorado's House Bill 22-1326, which last year increased criminal penalties for fentanyl possession. So it made possession in very small quantities a felony rather than a misdemeanor, so a much more serious charge. So we're analyzing the effects of this increased felonization on future involvement, MOUD, so medications for opioid use disorder, initiation and use, and overdoses, both fatal and non-fatal. And this work is rooted in community engaged qualitative work with those with experience in incarceration, substance use, and also interviews with treatment providers, policymakers, and law enforcement when they'll talk to me, which is kind of rare. But we're trying to get folks' perspective on the intersection between the criminal legal system, substance use, and overdose. And this is from one of our community partners, the Harm Reduction Action Center, and their kind of overdose memorial. So with this bill, they increased criminal penalties, which is what this country's done for many years for drug use, which hasn't really worked. And it also increases mandated treatment in jails. So there's like a lot of things at play. I kind of think of it as almost the opposite of Oregon's decriminalization, where they like increase criminalization, which happens immediately. And then there's also all these behavioral health services that are supposed to increase, but that takes a really long time. And so in Oregon, you're seeing kind of the opposite effects. And so it's kind of wonky, like how and when it plays out, but these are kind of the pieces of it. And they're all trying to address overdoses, but some by increasing treatment, but almost in like mandatory treatment, and then in increasing criminal penalties. So various things happening in our state around that now. Another thing I think those of us that have researched this are like very glad to now be doing things other than COVID work too. For the first couple of years of the pandemic, I was like really just looking at COVID spread in prisons because it was just insane. So we knew as people in the space that COVID would really devastate carceral facilities. It's really hard for folks to social distance. Prisons on average operate at 105% of capacity, so they're already overcrowded. And these individuals are more sick and have more comorbidities at baseline. So they're at really high risk for severe COVID. So the COVID Prison Project started in March of 2020 as an Excel sheet and became a national data project, including all 50 states. So the prison systems are all 50 states, the Federal Bureau of Prisons, ICE, and Puerto Rico. And we captured daily data, which has now been used to draft policy guidance around COVID in prisons and used as expert testimony to try and get people out who were really sick. We're able to document COVID cases, vaccinations, and death, and how transfers between prisons, or some examples here were how transfers between prisons were positively related to future COVID outbreaks. So we were trying to stop unnecessary transfers. But these transfers in prisons that they said weren't happening were still happening, and they were leading to kind of COVID outbreaks. We're also able to document how community case rates were contributing to COVID spikes in prison. That was when visitation was paused, so it was staff bringing it in. And then how those dying in prisons of COVID were substantially younger than those dying in the general population after accounting for those different age distributions. So this was a big beast of a project that I worked on to try to democratize data, because again, these data are often not publicly available on health and just conditions in prisons. And it was the first time that they were. All states created a dashboard and updated it with daily data. And so we tried to leverage this to expand this work beyond COVID to say, like, can we document what's going on behind these walls? And so that led to the creation of the Third City Project, which was named because the number of those incarcerated would make up the third largest city in America. And it was created to promote data transparency for the well-being of individuals and communities impacted by the system, shining a light on the data behind its walls, and is guided by a community advisory board of folks who've all experienced incarceration. So a lot of these data are supposed to be public. Again, can go into like as much as people are interested in that dynamic, but the federal Deaths in Custody Reporting Act does mandate that at least all deaths are made public in real time by these facilities, and they're not. So this really came about because we were trying to collate this COVID data, trying to explore other data. And the first project that we worked on to look at other types of health conditions or death was suicide deaths. And I looked at suicide deaths because prisons come with incredibly high levels of stress, a loss of autonomy, removal from social networks and communities, inhumane and often unpredictable living conditions, and little to no mental health treatment access kind of all create the perfect storm for these mental health crises in prison. And while suicides in custody have increased over time and are a leading cause of death in prisons, none of this is available real time. The national data often lags about 3 years behind, and there's still no data released during the COVID pandemic from the federal government. And last year, the Bureau decided to announce that they're not reporting these data anymore because it's no longer a mandate of Congress. So while trying to do this, I quickly realized it was not possible to document how many suicides were occurring behind bars because reporting is abysmal. So we just wrote a paper about how terrible the reporting is. So there's a lot of these states here in red, report nothing at all. States in yellow, including Colorado, report only very sparse and outdated data. So it's I think, been 5 or 6 years since Colorado prisons have released these data. Someone recently corrected me, which is true, that there's more updated jail dashboards in Colorado than prisons. So this was only looking at state prisons. So that's different, right, than jails, which are these shorter term facilities, often in every county, etc. And we're now working on publishing data just from the Federal Bureau of Prisons on suicide rates in prison, which we saw rise above the rates of the general population for the first time in 2020 during the COVID pandemic. And so another reason, right, we focused on suicide deaths is these should be reported and released based on federal law. Suicide, again, that's of incredibly dire conditions in prisons, but they shouldn't be happening because of how prisons are run and the types of oversight that exist. And prisons have an outsized role in preventing these deaths. They're also more likely to hide these deaths. And so investigative reporting in most states has found drastic underreporting of suicide. So there's a lot of kind of complexities here, but that's kind of a work. And closely related to this, types of to suicides are looking at kind of conditions of confinement that people experience. So another kind of line of work I've looked at is looking at solitary confinement, which is a really common practice in prisons and jails, where incarcerated folks are housed alone for 22 to 24 hours a day. And it's characterized by extreme conditions of isolation, sensory deprivation, and idleness. It's internationally recognized as torture, especially when it's used over 14 days with the Mandela rules. But almost all prison systems still use this. Something that has changed recently is prisons have rebranded. So there's different terms but interviews with folks incarcerated say it's still happening at the same amount. So I think it's just important when we look at these policies and programs, they haven't really changed. And unfortunately, in more recent years, especially since COVID, it seems like those not in solitary confinement are experiencing solitary-like conditions. And so not being able to go outside for over 6 months in the peak of the pandemic, things like that. And we know that experiences in solitary confinement place people at very high risk of suicide, overdose, and homicide within 1 year of release, and that there's a dose response to the amount of time you spend in solitary and the likelihood of experiencing these outcomes. We've done some historical work looking through case law. I've ventured somehow into legal studies here to see how solitary was also used in the HIV epidemic, to kind of show this isn't the first time it happened under the guise of public health. Like, I think we have to pay a lot of attention to history and how this was used against HIV positive individuals starting in the 80s in prisons. And while that was outlawed and not till 2013 in the last state, that it still happens, there's case law documenting solitary under the guise of public health. So that's kind of like a random note, but I think there's a lot of intersections here with just policy and kind of legal studies. So and with that, we kind of tried to work, and a lot of groups have worked to kind of define the difference between solitary confinement and medical isolation, because they should be very different, but they're often in prisons very similar. You're deprived of, you can't have in-person visitors, obviously, but then you're deprived of having a tablet to be able to actually talk to anyone outside and things like that, not being able to go outside at all. And we're currently working with data obtained through that Third City project that has weekly housing data, so regular population or solitary confinement and death records, to look at associations with in-custody deaths, because prior work's only been able to look at deaths after release. So trying to kind of expand some of the work here. And the last thing I'll kind of briefly go through a bucket of this work is about kind of the probation system and mental health. So I've thought a lot about probation and this kind of non-incarcerated type of involvement, and this stemmed from that first study, the SPEC study of PrEP and HIV prevention, right, was all folks on probation and parole. And a lot of people are telling us, like, we're not thinking of PrEP or like preventative care, but like, I am like so stressed and anxious all the time, and like, it just seemed like there was a lot about their mental health that wasn't very understood, and how this type of supervision was really stressful. So they often had this kind of constant stress of state sanctioned surveillance, really burdensome requirements such as movement restrictions. So some of that is house arrest, some of it is they can't leave the state, but with jobs such as truck driving, they couldn't get the job that they'd had before because they weren't allowed to leave the state. A lot of mandatory meetings during normal work hours, monthly fees, random house searches, drug tests, reduced job and housing prospects explicitly, right? Because if you have a record, you can't get a lot of different jobs or live in certain places. And those on probation disproportionately lack access to mental health treatment and other social services in their communities. So looked at the relationship between probation and mental health at the individual and county levels, kind of quantitatively, which I'm happy to go into more, but I started putting it in here and it was like 3 years of dissertation was like that, and so I took it out. I also did qualitative interviews with folks on probation and parole about how harmful it was, and so I'm just going to read a quote from one of those interviews that I think better encapsulates it. I'm trying to briefly tell you the results of these points. And so I think, yeah, this quote really encapsulates what involvement in the system does to health and overall well-being, especially when this system is used to try and address public health issues like substance use. So being involved in the system took my life from me. My life was actually pretty good. I found a little bit and was going downhill, but getting arrested and going to jail shouldn't have been the consequence for that, because it really fucked my life up. I could have gotten that turned around so easily and picked back up to where I wouldn't be homeless if someone just would have guided me the right way, instead of just arresting me and holding me. That didn't help me. That didn't help my addiction. That didn't help anything. They weren't addressing the real problem. Because of all that time I spent in jail and my record, the criminal background record is just, I've been repeating this a lot. These the itty bitty charges that they say misdemeanors, they're big. And they've screwed so many opportunities I would have had for my life. It sucks just to have a disease that you need help with, to have ruined my future because no one would help with that. They just put you in the system. I think instead of them sending me to jail, they should have sent me to inpatient rehab. They should have at least tried to knock off these charges that would follow me for the rest of my life. It makes me seem like I'm just this terrible person. That's not who I am. There's no hope. That makes you lose hope. I'm not even gonna try anymore. And I think there's a lot of anger and grief here that I think sometimes are hard to listen to or hold, but I read it to show these realities are really infuriating. Like, this is a woman who had 2 young kids who needed help, who lost custody of her kids because she couldn't get it. And a lot of these charges, she said, stemmed from not having a home and not having a place to go. And I think the hope and call to action here is that the system was one created through policy. It's changed through policy all of the time with how we think about different charges, different sentences. And I think there is an opportunity and a responsibility as the public health community to work towards this reality that does provide hope that she talks about. So I'll just briefly, again, I think I've like thrown a lot of different things out here because I didn't know quite exactly what would be most interesting or relevant. So apologies if it's hard to follow, it probably is. Things I've learned in talking with community organizations here, some policymakers, and trying to see what would be most useful for me to kind of explore next, especially in the state, is looking for among folks on probation, the criminal, legal, healthcare, and kind of structural predictors of suicide in Colorado. So there's not a lot known on that among people on probation. And doing this work around the increased fentanyl felonization, I think it's important that we talk to folks who have a recent fentanyl related felony, which we've not done yet. So hoping to do some qualitative interviews around that. And then something that's come up in a lot of these conversations is how we know people before they're involved in the criminal legal system have a lot of trauma and things that are self-medicated that lead to involvement in the system. And that afterwards, people have a lot of barriers to maintaining health and well-being and to accessing care, but there's not a ton understood about the trauma kind of endured while incarcerated, especially around PTSD. Is something that we've heard people say they got a diagnosis after prison. If you don't have one before, you're gonna have one when you get out. And so kind of trying to understand that, and there's a lot of solutions here that are rooted in having treatment in prisons. And what I've heard from interviews with folks who are incarcerated or have been incarcerated is that you can't provide treatment in a traumatic environment. Like, it's just not going to work. And so how do we address that in ways that also try and realize that the system is huge and still exists? And so we can't just say, like, you have to decarcerate people. There's always these tensions of like, how do we improve the system that is while trying to change it at the same time? So anyways, most of all of this work happened when I was still at UNC. So the thing I received there, and thank you. I'm happy to chat more and hear your thoughts.
Thank you so much. This is like an unlocked Zoom meeting, so any participants are able to unmute themselves and ask a question or raise their hand or put something in the chat. And maybe while people are collecting their thoughts, because it is a lot to absorb, I'll get the privilege of the first question, which maybe, I mean, are there any models, I guess I'm thinking of US states, but probably globally too, of how to move forward? I mean, you kind of mentioned Oregon in passing, and I wasn't sure, but I think you were implying that their model was better than Colorado's, if I followed, or maybe just different. But are there, yeah, what's kind of cutting edge that might be one positive, direction?
Yeah, no, I think it's a great question when I think about a lot. And I think with Oregon, I don't necessarily mean it's better. I guess it's like the opposite. Instead of increasing felonization, it's decriminalizing. And I think what we have seen so far there is like, there's all this pushback because of the increased drug use, and there's an increase in overdoses. And I think we haven't let the behavioral health interventions that are coming with that, they haven't been implemented yet. So it's like, you're catching them kind of in the middle of this huge change. It's pretty dramatic for the US, right, of decriminalizing a lot of drug use. I'll say, since I've come here, I've learned a lot more about substance use and harm reduction and with the fentanyl work, but had not done as much of that before. But what I have learned, at least in some ways, is kind of the work in Canada around the overdose prevention sites and needle exchanges, at least from a drug use perspective, that they seem to have a more progressive take to that. But there's, mixed reviews, I think, there. I mean, there haven't been any fatal overdoses at the overdose prevention sites, the couple that exist in the US, I believe. And so that is like another model. There's also from around like the criminal legal system, like culture kind of. I know there's a lot of work that Amend does, which is based at UCSF, that goes to I think it's Norway is their main partner, that learns about how the prisons kind of like operate there. And the general thought there is people are treated much more as human, or at least they have a couple prisons that operate like that. And that the culture is just very different, and that they've tried to kind of train staff at prisons here in the US, mostly in California, on that model. And just like, I'm trying to think of some examples, but folks who are incarcerated have access to full kitchens with knives and things that like we think of as just, it's like if you're treated as human, like there's just ways that, people can become better or different in ways that I think our system doesn't really allow. And so I don't know how well I answer it, but there's like little pockets of ways that systems have done it differently, but those places obviously have different histories of incarceration and jail.
Just making sure no one on chat. So I so appreciate you shedding light on obviously a multitude of issues that can go on with the criminal legal system and its impact on health for individuals and communities as a whole. That's an extraordinarily important contribution. I think what I wonder a lot about is how you engage or not the criminal justice system broadly, because I think you're facing a lot of issues in this work of they're likely unwilling in some sense to partner on a lot of this. You made just kind of a side comment of when they'll talk to you, but I've experienced that as well, right? So I think it's really tricky to say, I want to put this approach or this kind of shed light on this issue when so much of what you do is wrapped up in the criminal justice system and it's their issue, they're taking care of it. So I just wonder how you thought about and interacted with that system or plans for it as well, of I just feel like you have to have both systems move together and just what you do in your role.
Yeah, no, I think that's a great question and one I grapple with a lot, because I often talk about it, how it's not this simple and they're not that. A lot of them work together, but I think of it as like two kind of camps with this work, where at least where I came from UNC, it was pretty drastic. There was a group in the Injury and Violence Prevention Center there that worked on like criminal legal issues, and they partnered a lot with the Department of Corrections to get much better data. And they were limited in the questions they could ask and what they could say in their papers, and it required a staff from the prison to be on their papers. But they got really good data that you could actually do much more like causal work or understanding a lot more about the system in that way. And I think if you're going to change anything at the prison level, like that is a way to do it. The other group that I kind of just happened to work with more was in the School of Medicine, and they did not collaborate with prison officials because they were unwilling to compromise the type of work they could publish. But it really resulted in, this third city these projects that are trying to like web scrape and get these data from legal requests and all of these other ways. And because they wanted to say, like, we think you should let people out as a solution to a lot of these issues. We think it's a traumatic environment, these things that you're finding. But they do, but at the same time, a lot of those people actually work together and there's other realms. But I think coming here, I was like, well, what do I want to do? I think it's tricky not having had the experience of partnering with prison jail officials of like how to do that. And like, I don't think they're really going to read my research papers, but they're pretty damning about the system. If they did, they probably wouldn't and let me in. And what I've heard is it's hard to get in and it's really easy to get shut out because they control your whole access. And so I'm working more with the jails so far in like Arapahoe County. Because I know folks who work at a programs level with folks coming out of jail. So I went to the behavioral health committee at the sheriff's office last week and just kind of listened and like talk in those spaces about how, you know, I want to improve outcomes for folks. And I think behavioral health is I don't know how to say this right, but it's easier, like a lot of those officials, like the jail folks working at the jail, don't want folks with severe mental illness and substance use issues in their jail. So like they recognize that's not how these folks should be treated. And so that I think is a space I'm a little more comfortable being a little more honest about my perspective specifically there. Because they also, at least in the Denver area, are like, we shouldn't be incarcerating folks who have these needs and we can't meet these needs. So there's space there to also say like, I do think if we address these issues in a different way, like your jobs would be a lot less stressful. Like you have huge issues with retention of staff, partially because you're dealing with all of these public health issues that you shouldn't be dealing with. So I think there's like some space to try and show them that like your work would be easier if you didn't have to deal with X, Y, and Z, but it's a current like thing I'm kind of thinking through of how to. I got connected with, Vivian Keyed also, it's at Denver, UC Denver, who works with the prison, but she's very like willing to say, you know, like what kind of research do they want, and do that as well to get access. So yeah.
So we have a question in the chat, 2 parts, and maybe I'll read you the second part first because it might be a quicker answer. Who created the logo for the COVID prison project and the basis for why handcuffs and the virus depiction was the choice to represent that work?
Yeah, so the first one, I don't know yet in Colorado. I know there's a lot of work that's based at the University of Minnesota that Rebecca Schlafer has led about maternal care and perinatal care in prisons. She's awesome and has done a lot. There's also these kind of prison doula projects in a few different states where prison systems have, because you're not allowed when you give birth, often have the only person in that room besides the physicians is the guard. And so there's been some progress in allowing a doula who's been incarcerated themselves to come into those rooms. So I would say that her work, and based out of Minnesota, speaks the most to that, but I'm not sure in Colorado specifically about those data yet, but I'm learning about kind of how to get these data, what is available, what people are able to share or willing to share. But generally, I think like data on birth themselves would be less restricted than data on things like suicide, or officers or like the staff would be less hesitant to share that because there's not really a reason like we feel like birth shouldn't be happening or something, like suicide shouldn't be happening. So I'd be interested in that. But what we did in North Carolina is there was really one main hospital system, the UNC hospital system, where everyone from the women's prison went. And so we're able to get data from UNC hospitals, link de-identified with women's prison information, and that's how you could do that. So I wonder if in Colorado, I imagine there's probably 1 or 2 women's prisons, they've probably received treatment at 1 or 2 medical centers, and you could get that kind of medical data. That's how we've also linked data by not collaborating directly. That was a long answer. And then the COVID prison project, I am trying to remember if that was a student, a different site, so it was a multi-site project that may have made that. And I will say since then, the team, and right, I was an RA on the team, so I'm trying to remember who was making the decisions. It was the PIs of it, but I will say since then they've moved away from using like handcuffs and things in imaging, and now, right, kind of the Third City project, you could see as kind of a city landscape. Like they've tried to move away from these like more carceral depictions in logos, which is a specific choice, but I think there's really interesting conversations right now. I think it just came out in Health and Justice, recommendations for visuals used in presentations around the criminal legal system and substance use. And they talked with people who've been incarcerated and struggled with substance use about what images they liked or didn't like. But then we talked about it with folks with those experiences as well, who had like mixed views of like, we want this to not be, triggering imaging. We don't want it to also be like, patronizing imaging, but we also want to be honest. So for example, showing a solitary confinement cell, some people were like, no, I've experienced that and I need people to see how awful it is, versus like trying not to, I don't know if that makes sense. So I think there's like I think that's a really good question, because there's a lot of discussion as to like how, if and how to depict certain parts of carceral environments, in like academic.
There's another question in the chat, and maybe it's easier if you just read it. Work with the Colorado Department of Corrections. I can say there's a desire to improve the system and a huge movement in our clinical department to ensure we have individuals with substance use disorder have access to medicated assisted therapy and behavioral health resources. We have room for improvement. There's someone who came from outside the system in January of this year, and part of the system, there's a ton of work being done. And I'll follow up by saying, yeah, where do you find optimism in your work?
Yeah, no, I would love, I've emailed like many times all the physicians working on like the MAT stuff in the Department of Corrections with crickets. So if you send me to someone, I'd love to talk to them or talk with you. Thank you. I think part of it is struggling to figure out who to reach out to, because I do believe like, you know, there's people who really want change in the system and like for the better. And sometimes people are restricted with what they can and can't say to like an academic. I know there's a lot of hierarchies and levels of command that like I don't really understand. But I do think there's like, you know, work being done, especially around MAT and like behavioral health needs, right? Because there's this recognition that like this is not the best place to treat these things. So like how can we improve what we have too is a push for that, especially with the bill last year that mandated more treatment being done in prisons and jails. Yeah, so I think there's like hope in things like that as an example, kind of moving forward. And that this is cheesy, but because I do a lot of qualitative work too, like talking to folks who've been in the system, just like that someone cares. Like they're like, I've not been asked just like, how am I? Or like, tell me about your life. And so I think there's both there and talking with them and the kind of change they want to see and trying to do that. And that there's been I think there's wins, like, because each system is separate within the state and each jail is its own separate entity in the county, like, I'm sure there are, you know, wins or like changes happening, that are, yeah, that sometimes you don't see on the outside immediately, but they're happening. So I'll copy this email address.
Great. And I think we have time for just maybe one more question, before you wrap up. What is your recommendation on the socialization of informal control and medical control in prevention practice?
I'm not sure I understand some of those terms. I'm sorry.
Oh, yeah. I just want to say your talk centered on the legal control in the system level. You measured those consequences in the health and even suicide. So the legal control is one type of control in contrast to informal controls at home, at school, workplace, and the medical control such as healthcare system. So what's your recommendation on the socialization of informal control and the medical control in the prevention practice in order to reduce the burden we see in the legal system?
You mean like types of, I'm trying to think of criminal legal like presence in schools,
yes.
or
Yes, in the population level, we are trained in public health for social epidemiology. So what's the callback for prevention practice, what we can do? Maybe I follow up with you another time. Sorry about this. Thank you.
yeah, no, I think it's my fault. I'm sorry, I'm struggling to understand the exact question, but I think I'll give one small example that might not be exactly that, but I think something, you know, my group looks at is generally that like severe punishment is not a solution. And so, in thinking about just the school environment, like with, oh, now I'm totally forgetting the school resource officers, who are really carceral officers there to punish, that, you know, school social workers are like going to address a lot more of those needs. And I think it's a similar, yeah, like you said, similar framing to these other spaces as well. I think people are often scared of going to the emergency department if they have a warrant out or something. So being sure there's not like police in those spaces, that there's other ways it shows up, in those examples.
Thank you. Yeah, we talk more. Appreciate it.
Well, with that, we'll close for today. Our webinars, as always, are recorded and posted on our YouTube channel. So if you have any interest in gaining access to the recording and have trouble finding it, please reach out to us and let us know. And I'm Ashley Brooks Russell. I think I'm pretty Googleable. So thank you, everyone.